Guess we're just about to get started here. In case anyone doesn't know, I'm Mark Kirkmay, Philanthropy Officer for TB Vets Charitable Foundation, and we're presenting with Hannah Lishman. Is it Lishman or Leishman? I don't know.
It's
Ah,
Lishman.
okay, Lishman. Thank you for clarifying. Hannah Lishman here, talking about preventing childhood asthma and allergy. So I will hand it over to you, Hannah, whenever you're ready.
Thank you. Let me just share my screen here.
Just a quick note, if anyone that's entered a little bit late, we'll do questions at the end, but you're welcome to just put them in the chat so I can keep record of it.
Great. Thank you, Mark. Can you see my slides?
Yep, it looks good on my end.
Great. Okay, I'll get started. So thank you everyone for joining us this Monday morning. My name's Hannah Lishman. I'm the Senior Scientist for Community Antimicrobial Stewardship at the BC Centre for Disease Control. I was previously a UBC postdoc with this team. And so the work that I'm going to talk about today kind of comprised my postdoc and is continuing on into our program's work plan going forward. So today we are talking about preventing childhood asthma, so putting evidence into action. So I'm going to talk a bit about the research that we've been conducting into this area over the past few years, and then end with some of the knowledge translation that we've been doing and that we plan to do over the coming months, which has been generously supported by our donors. So the research component of this work was supported by a CIHR project grant, and the KT, the knowledge translation work, has been generously supported by the Pacific Public Health Foundation. Let me just switch. So I'd first like to respectfully acknowledge that I live and work on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh, as well as the Coquitlam nations. I'd also like to say that the data for our cohort studies were collected on the traditional unceded territories of all First Nations across British Columbia, as well as from Treaty 1 territory and the traditional homeland of the Red River Métis in Manitoba. Also, a note of thanks. So on behalf of myself, the asthma research team, and the Pacific Public Health Foundation, we'd like to express our sincere gratitude to TB Vets Charitable Foundation for their generous support of this work. Donors such as TB Vets make it possible for PPHF to support and implement programs and projects grounded in the most pressing health priorities for BC, including the Asthma Project. And this is a collaborative initiative between BC CDC and UBC, as I mentioned before. So thank you. Some data disclaimers, I won't get into this. So firstly, a note on terminology. I'm going to be using human milk, breast milk, parent's milk, all of these terms relatively interchangeably. However, data set derived terms that may be more gendered will be used where data and results are being discussed. If the method of feeding human milk is relevant, it will be mentioned. Okay, bit of background. So let's talk about asthma and atopic disease to start with. So allergic diseases affect hundreds of millions of children worldwide. And we know that asthma is the most common chronic disease of childhood, affecting anywhere between 8 to 18% of children in Canada. It's one of the most common reasons for missed school days, as well as subsequent work days for caregivers. So it places quite a high burden on children in Canada and their caregivers. And developing asthma in childhood has impacts on asthma persistence over the life course. But what we also know is that incidence of asthma, so the new cases of asthma being diagnosed, is actually falling in BC and has been for quite some time. So this green line at the top here is asthma incidence in children aged 1 to 19, so quite a broad age group, but it has been falling over the last 20 years. And we see down here, this is some of our work that asthma incidence in children under 5 in the red line has also been falling over the last 20 years. We also know that eczema, hay fever, food allergy, and asthma often co-present in the same child, and this is often referred to as the allergic march or the atopic march. So you may be wondering why someone who works in antibiotic stewardship is talking about asthma. And that's because we believe that there's a connection between antibiotic use and asthma development. And the mode of action that we hypothesize is through changes to gut bacteria early on in life. And I'll talk a bit more about that now. So we know that there are prenatal, intrapartum, and postnatal influences on the initial seeding and the subsequent colonization of the infant gut microbiome, which has impacts on metabolic pathway development and immune system training. We also know that disruptions to a healthy gut during these crucial early days of immunological development can have impacts on disease outcomes later on, and disease outcomes in particular that are inflammatory, such as asthma or allergy. So essentially, the types of bacteria that live in the infant's gut, and particularly the diversity of that ecology of bacteria within the gut, help to train a child's immune system, which is very immature when they're first born. And so influences on the makeup of these bacteria in the gut can have impacts on how that immune system is trained, and that can have influences on their disease trajectories later in life. So how are gut bacteria and allergy actually linked? So we know from the literature that gut microbial ecology is significantly different in children who do and do not develop asthma and atopic disease. In particular, these 4 bacterial genera, I'm not a microbiologist, so I'm not going to get into it, but these 4 bacterial genera, differences to these bacteria are particularly crucial in playing a role in immune system development as it pertains to asthma. Dysbiosis or disruption of bacterial growth in the first 3 months seems to be the most critical to clinical outcomes. And it has a number of impacts on immune system development listed here at the bottom. Again, I'm not an immunologist, so please don't ask me questions about specific immunology. But this is a brilliant paper from our colleagues at UBC, and with the child study, the Canadian Healthy Infant Longitudinal Development Study, showing that delayed gut microbiota maturation in the first year is a hallmark of 4 different pediatric allergic diseases. So food allergy, atopic dermatitis or eczema, asthma, and allergic rhinitis or hay fever. So if the development of a child's microbiome is delayed through factors such as antibiotic use, it appears to have an impact on the development of all 4 of these allergic outcomes. So other studies have also looked at this question around antibiotic use in infancy and allergic disease, albeit usually in much smaller cohorts of children. But this is from a meta-analysis, so a study looking at lots and lots of different studies and compiling all the results together. A meta-analysis of 51 studies, and they found that children who were exposed to antibiotics early in life had over 2 times the odds of developing asthma in childhood, and that there were also significantly higher odds of developing other allergic diseases as well. It also showed that exposure in the first 3 months appeared to be the most important. So this, I'm going to spend a little bit of time going through this because I think it's fascinating. So what role does human milk play in this pathway? So there's a number of different ways that the gut microbiome can be disrupted, or that the seeding of the gut microbiome can be different in different children. One of those factors is a genetic predisposition to asthma. So let's say the mother has asthma. Another way is antibiotic administration. So on the left-hand side, this is from a study from the child study that I mentioned before, looking at infants born to mothers with asthma and without asthma, and looking at how they were fed. So in infants who had a genetic predisposition for asthma, those who were breastfed had a much lower risk of developing asthma compared with those who were not breastfed. But when we look at kids who were born to mothers without asthma, so they did not have a genetic predisposition, the mode of feeding didn't seem to make any difference at all in terms of their asthma outcome. And over here in this study, this is looking at whether the infants received antibiotics or not and how they were fed. So in infants who were antibiotic exposed, but were breastfed, they had a slightly higher risk of asthma compared with kids who were not antibiotic exposed. And this increased risk was not significant. However, in infants who were antibiotic exposed and were not breastfed, they had 3.5 times the odds of developing asthma compared with kids who were not antibiotic exposed. So essentially what this is saying is that human milk in and of itself does not prevent asthma or allergic disease. But in infants who have an otherwise predisposed state of developing asthma, so if they were exposed to antibiotics or they had a genetic predisposition for asthma, human milk appears to act to mitigate that risk. So in other words, it acts to restore an otherwise disturbed gut microbial environment in infancy. It feeds the bacteria that are killed off, thereby restoring that normal immunological training process. That's what appears to be happening, which I think is absolutely fascinating. Also, a lot of the literature shows that it's not exclusive breastfeeding that's the key, it's any kind of breast milk exposure. Okay, so moving on. So then what our team started to look at was this kind of reduction in childhood asthma over the last 20 years that I mentioned before. And they also found that over the same time period, there was a 77% reduction in the use of antibiotics in infants under 1 over the same time period. And these two trends were significantly associated with one another. I'm just going to say from an antibiotic stewardship perspective, this is an enormous success story. This is an absolutely unprecedented reduction in antibiotic use in babies, kind of globally, really. And I will also just take a moment to say that we have not seen a subsequent uptick in the rates of secondary severe bacterial infections. So we're not so far seeing an unintended consequence to this reduction, which tells me that this reduction was in unnecessary antibiotics that weren't needed in the first place. So it's a huge success story. But our team noticed this kind of these sort of twinned reductions in these two rates, and it piqued our interest. As part of this same paper, we collaborated again with our colleagues at the Child Study to look at this association in a pretty small group of kids, about 2,000 kids. And they found that in kids who received antibiotics in infancy, they were at over 2 times the risk of asthma later in childhood. However, like I mentioned, this was in quite a small group of children, and our previous ecological work was not in individual infants, so we weren't able to adjust for individual differences between the children. So that then led us to design our current study, which is a retrospective cohort study recruiting all infants born in British Columbia and in Manitoba, because that was the only other Canadian province that had a comparable level of data collection to BC and an interest in this study question as well. We recruited all infants born in these 2 provinces between 2001 and 2011, and we followed them all up to age 7. We also built in a parental look back period of 5 years before each birth. So our recruitment period was 2001 to 2011, and our full data set was 1996 to 2018. Our exposure was, of course, antibiotics before the first birthday, and we looked at this in a number of different ways. And our outcome, we expanded upon the previous work to look at asthma, eczema, or hay fever by the 5th birthday. And our study protocol is published here in BMJ Open if you'd like to see how we did everything. So as you can imagine, this is an extremely complex question with a lot of different potential risk factors at play. And so in order to capture all of them, we conducted a scoping review to identify potential covariates, assess the pros and cons of different study designs, look at how outcomes are captured, and identify common limitations that we could hopefully design out of our study. And so I've kind of grouped our risk factors into 3 different groups relating to the parents, to the baby, and to their environment. So with respect to the parents, we collected data related to maternal age, BMI, prenatal smoking or substance use, prenatal and intrapartum antibiotic use, diabetes, mother's and father's history of atopic disease, as well as maternal education. In terms of the babies, we looked at their mode of delivery, so whether they were vaginally delivered or cesarean, the sex, gestational age, season of birth, number of older siblings, immunization completeness by their first birthday, number of respiratory tract infection visits, and likelihood of human milk exposure. And then with respect to the environment, as many people in the audience will probably understand that obviously we have to take account of air quality when we talk about asthma and access to outdoor spaces. So we looked at the rurality of their residents, material deprivation, greenness, area level greenness, as well as area level air quality indicators, primarily nitrogen dioxide and fine particulate matter. And fine particulate matter captures wildfire smoke, which is particularly relevant in BC. I won't go through this, but just to say these are our BC data sets that we use to collect all of these data, and these are our Manitoban data sets. As best as humanly possible, we matched data set to data set so that we were running these studies kind of concurrently next to each other, but they were as similar as they could possibly be. That's the same for our exposure, our outcomes, our covariates, everything. We worked in concert with each other to try and match. I won't go through these, but just to say there were a lot of data sets to wrangle. This is a complicated slide, so I'm not going to spend too much time on it. But essentially what this is it's called a directed acyclic graph. And you can kind of think of it as a conceptual framework of your question. So over here with the play sign, this is baby antibiotics. This is our exposure, as I said. And over here at the stop sign is allergic outcomes. So this is our outcome. So the arrows are flowing from exposure to outcome. And we're hypothesizing that this effect is occurring through changes to the baby's microbiome and their immune system training. And then everything else is all of our other risk factors that we believe to play a role in this relationship. Each arrow is representing that one factor has an impact on another. All of these arrows are supported by the literature from that scoping review I mentioned. And essentially what this allows us to do is to build our final epidemiological models in a way that makes us confident that we are not missing potential sources of bias that we could have accounted for. There are a few factors in this diagram that we didn't have data for, such as pets or daycare attendants. So that was a bit of a limitation, but we were able to collect data for almost every factor shown here. So essentially what you can take away from this slide is that antibiotics, we do not hypothesize that antibiotics are the only risk factor related to asthma development, that it is a very complex pathway, and it's our job to try and tease apart the individual effect of antibiotics, accounting for everything else. Very briefly, for those who are interested, we used univariate multivariable logistic regression models to determine the odds of the outcomes. I feel it's relevant to mention that we added a cluster function into our models to account for the fact that mothers could have multiple infants in the study. And we wanted to recognize that children raised in the same home were more likely to be similar to each other with respect to their risk factors than children raised in different homes. So we clustered on mother's ID. These are some methods for how our environmental variables were collected, a bit about missingness, I won't go into that. And then final models were run on a complete case basis. Okay, let's get into some results. So we're waiting on some Manitoba results, so I will make it clear where I'm talking about BC and where I'm talking about Manitoba, and they'll kind of be sprinkled in throughout the presentation. But in BC, we started with an extract of 464,261 infants. And after applying our exclusion criteria, our final analytical data set was 342,686 infants. Our exclusion criteria were excluding infants who were placed for adoption within 28 days of birth, infants who were born as part of a multiple birth, as well as preterm infants. And then, of course, we had some loss to follow up. So some children who moved out of province before they reached their 7th birthday, we obviously couldn't fully follow them up, so they were excluded from the study as well. So some descriptive results. So 36% of our infants in our cohort received antibiotics in BC, and 43% received antibiotics in Manitoba before their 1st birthday. This bar chart is just showing the number of infants receiving antibiotics by their year of birth. So we can see that total antibiotic use declined over the study period, as we would expect. And then these different colors are just the different classes of antibiotics that the babies received. The most common was amoxicillin, so beta-lactam penicillins. It's the most common antibiotic used in babies. And then in terms of the number of antibiotic courses that kids were receiving, in BC, most were receiving 1 course, 55%, less so 2 courses, and even less so 3 or more courses. Whereas in Manitoba, you actually saw quite a few infants receiving 3 or more courses compared with BC. In terms of our outcome, so this is for BC, 9.3% of our kids were diagnosed with asthma before their 5th birthday. 0.63% were diagnosed with eczema, and 0.91% were diagnosed with hay fever. The keen-eyed people in the audience will see that those are quite low numbers for eczema and hay fever. And if anyone is a parent in the audience, you'll probably know why. And that's because you probably wouldn't take your child to the doctor if they had an eczema flare-up or hay fever, unless it was very severe. You'd probably just take them to the pharmacist and get something over the counter. So because we were relying on clinical diagnostic codes, that's a limitation of our study, is that it's likely quite a big underestimate of the true case burden of eczema and hay fever in the province. We're most likely just capturing the most severe cases. However, for asthma, we're pretty confident that this is a true reflection of asthma burden in BC, because if your child does have difficulty breathing, you will be taking them to the doctor. So down here we have asthma. The light blue line is boys, the dark blue line is girls. So we see asthma going down for both sexes over the study period, and boys consistently were more likely to be diagnosed with asthma than girls. Up here we have eczema. It's actually going up slightly over the study period. However, again, like I mentioned, these are quite small numbers. And then hay fever going down slightly, more so for boys over the study period. And then these are our final adjusted models for the 3 outcomes. So the top model is looking at asthma as our outcome. So after adjusting for all of the variables listed here, this is basically telling us that kids who received antibiotics in their first year were at 63% higher odds of developing asthma than kids who did not receive antibiotics in their first year. And this was a highly significant, statistically significant result. The middle here is eczema. So kids who received antibiotics were at 19% higher odds of developing eczema compared with kids who didn't, adjusting for these factors. And then kids who received antibiotics were at 43% higher odds of developing hay fever compared with kids who did not receive antibiotics, again, adjusting for these factors. So we're seeing quite a clinically and statistically significant increase in the risk of all 3 atopic outcomes in kids who received antibiotics after we adjust for all sorts of factors that I mentioned before. But we didn't want to just stop there. So we wanted to perform some sensitivity analyses and really dive in to these associations and try and tease them apart a little bit to understand them better. So this is essentially, I'll go through this very quickly, don't worry. This is essentially a conceptual map of our sensitivity analyses to try and map out exactly what question we're trying to answer each time. So this is our main cohort up here from which we ran our models that I just showed, our main models. And then we wanted to subgroup the data to investigate specific questions. So our first sensitivity analysis, we wanted to try and address a common critique of this question, which is called confounding by indication. And essentially what that means is, people say, isn't it just the effect of the respiratory tract infection early in life that is predisposing a child to develop asthma, and not the antibiotic that's being used to treat that respiratory infection? Is it the infection that's doing the damage to the lungs? And is that lung damage causing asthma later on? So we wanted to investigate that by looking at what the children were being prescribed the antibiotic for. And we wanted to firstly look at kids who had no record of a respiratory tract infection in their first year. And amongst that subgroup, compare kids who did and didn't receive antibiotics. So the kids who did receive antibiotics in this subgroup were likely receiving them for things like urinary tract infections, gastrointestinal infections, heaven forbid a blood infection, anything other than respiratory. And when we looked at this subgroup, we saw that kids who received antibiotics were at 77% higher odds of developing asthma compared to kids who didn't, after adjusting for all relevant covariates. So we're still seeing a very strong clinically and statistically significant result there. And then similarly, we wanted to look at kids who did have at least one respiratory tract infection visit in their first year and compare those who did and didn't receive antibiotics. And again, we see 54% higher odds of asthma in kids receiving antibiotics in the group who only had at least one respiratory infection. So we're still seeing quite strong signal there, even when we subgroup the data. And then, as I mentioned in the background, the timing of antibiotic administration appears to be important, or the timing of that disruption of the gut microbiome appears to be important. So we wanted to look at the time at which the infant first received their first antibiotic course. And we found that kids receiving their first antibiotic at 0 to 3 or 4 to 6 months were at higher odds of developing asthma compared with kids who received their first antibiotic at 7 to 9 or 10 to 12 months. So that's quite consistent with what we see in the wider literature where they look at smaller studies. We're seeing a consistent result with them. And then we wanted to look at, we wanted to try and address this issue of potential reverse causation. So we wanted to look at kids who maybe weren't diagnosed with asthma in their first year, because that's quite uncommon to diagnose asthma that young, but we're nonetheless consulted with a kind of wheeze condition. So we wanted to exclude infants who had a diagnosis of viral wheeze, recurrent wheeze, or bronchiolitis in their first year, and rerun our models again. And again, we found the kids receiving antibiotics had a 52% higher odds of developing asthma compared with those who didn't. So we're still pretty confident in our result at this point. And then our last two sensitivity analyses, we are still finalizing, but just to tell you that they're happening. So it's very difficult to get breastfeeding data in that's routinely collected in both BC and Manitoba. So what we do have is breastfeeding upon discharge. So when the parents are initially discharged from hospital, has mom or the breastfeeding parent attempted breastfeeding? So we have that variable in the models, but we wanted to go further. So we're using the child study, which does have long-term follow-up of breastfeeding outcomes in their smaller group of infants. We want to use that data set to build a predictive model for likelihood of breastfeeding behavior based off of maternal factors that we have in our cohort, and then impute that likelihood variable into our cohort and rerun our models to investigate this idea of effect modification that I talked about at the beginning. So we're currently finalizing those results. And then lastly, as many in this group will know, asthma is a very complex disease that has a lot of different phenotypes. And so we want to, we're just finalizing the results now, where we're looking at different trajectories of asthma over over childhood, the child's first few years of life, to filter out transient cases of asthma, and then rerun our models and see how they behave when we just look at kids with chronic asthma, see how that compares with our main models. Okay, so the limitations of this work, as I mentioned before, are that outcomes are based off of clinical diagnostic codes. So as I said before, eczema and hay fever are likely an underestimate. There's also potential for misclassification of asthma because we're not directly measuring asthma ourselves. We're relying off of these diagnostic codes, which is possibly why we see reduced associations compared with smaller prospective cohort studies in BC, where they were able to directly clinically assess the children themselves. And as I mentioned before, we do not have data for all variables in our theoretical framework. So there's some potential for residual confounding. However, the variables that we don't have data for in the literature, they don't have huge effects on the outcome. So I'm confident that we have covered the main ones in our study. So just to summarize, 63%, 19%, there was a 63%, 19%, and 43% higher adjusted odds of asthma, eczema, and hay fever, respectively, by age 5 in infants receiving antibiotics in infancy. The association with asthma was robust in children receiving antibiotics for non-respiratory infections only. Children receiving their first antibiotic earlier in infancy had a higher odds of developing asthma. And associations with all atopic outcomes supports our hypothesis that the mechanistic pathway is immune regulated and influenced by gut microbial dysbiosis early in life. So this potentially has implications for asthma and atopic disease prevention in the future. And it also potentially has implications for antibiotic stewardship programs, as well as lactation supports, which leads into our KT work. I've got a couple slides here and then we'll finish up. So this is the work that's been generously supported by PPHF and its founders, such as TB Vets. So thank you again. So our main project that we've been working on is hosting this research topic in the Frontiers Journal group. It's been cross-posted across Frontiers in Public Health, Frontiers in Pediatrics, and Frontiers in Allergy to try and attract as wide a author audience as possible. And it is called Preventing Childhood Asthma, the Neglected Impact of Existing Public Health Interventions. So that's mainly referring to antibiotic stewardship, support for breastfeeding, as well as improving air quality. So this journal series is open access, and through the support of our donors, we've been able to cover all article processing charges for all of our authors. So we've reduced the barriers for both readership and publishing. If we get to 10 articles, this will be also published as an ebook, which I believe will be a really sort of state-of-the-art valuable volume on this subject going forward. We're really, really excited about it. We currently have confirmed interest and submissions from across Canada, the UK, Switzerland, Australia, South Africa, Ethiopia, and China. And we wanted to capture as many parts of this mechanistic pathway as possible. So we currently have articles relating to the epidemiology of childhood asthma, immunology, genomics, metabolomics, economic modeling, symbiotics, breastfeeding, and policy considerations in lower and middle income countries. We have a real spread of subjects so far. The deadline for submissions is the end of May currently, so we are coming to the end of this project. And it is co-edited by an amazing editorial group. So it's led by David Patrick at BC CDC, Megan Azad at University of Manitoba, who just recently won a Gardner Award, which is extremely prestigious. We're very, very proud of her. Stuart Turvey at BC Children's Hospital, Angela Dramowski at University of Stellenbosch in South Africa, as well as Petra Zimmerman in Switzerland. So that's been a big focus of our knowledge translation so far. We've also constructed a stakeholder advisory committee, which is made up of clinical partners, allied health partners, so midwives and lactation consultants, policymakers, so Ministry of Health representatives, as well as most crucially to us, parents of young children. And they come from all health authorities in British Columbia, so they're from all over the province. And they serve to really help guide our outreach strategy and how we can best find homes for our new evidence, and also for the wider body of evidence, not just our study, but all the work that the child study has been doing, as well as other cohort studies. So they've been talking to us about, they'd like to see this evidence in Baby's Best Chance, in prenatal curricula, in the Perinatal Services BC Pregnancy Hub. They've been really helping us to develop this strategy going forward for how to conduct our knowledge translation in the province. Our partners, Mohsen, Sadat Safavi, and Harry Lee at UBC have also recently just submitted a paper to our Frontiers series on attributing asthma and allergy related cost savings to antimicrobial stewardship in the community. So we believe that if you add on the additional cost savings related to avoided asthma cases to, if you attribute those cost savings to antibiotic stewardship, then that just enhances the argument for investing in antibiotic stewardship in the community. So that's been some really valuable work in this area as well. We've also presented our work at local and international conferences. So last year, I attended the American Thoracic Society conference, which is largely a respiratory audience, to present some preliminary findings. And later this month, I'm heading to Copenhagen to present our finalized results at the European Society for Pediatric Infectious Disease, because we're trying to reach an international audience as well and see if other jurisdictions can replicate this work too. And then lastly, we're currently seeking funds to complete video materials of the research findings for soon to be and new parents in BC. And then, yeah, this is very much a huge team effort. This is our team, all of our amazing co-authors from UBC, University of Manitoba, BC CDC, the Child Study, and BC Children's Hospital. And as I mentioned at the beginning, the research was supported by a CIHR project grant, and the KT has been generously supported by PPHF. So thank you to TB Vets as well, obviously. So that is it from me. Maybe I'll stop sharing and we can have some questions. So I see a question here in the chat. Are there any differences in asthma rates among different visible minority groups? We do, yes, so we do see some heightened risk of asthma in the South Asian population in some jurisdictions. It's kind of a very difficult thing for us to assess in all sorts of studies, really, because it's difficult to capture self-identified ethnicity data and treat it properly. However, we did collect data from the census. It was an area level percent visible minority indicator. As an attempt to try and address this in our study, it had a very high rate of missingness. So there was a lot of missing data there. So we weren't able to include it in our final adjusted models, but we are doing what's called multiple imputation, which allows us to impute missing data in a way that doesn't introduce any bias. So once we've run those imputed models, that variable will be included, and I'll be able to speak to that question more directly. Are there alternatives to antibiotics treatment for infants? So this is a really interesting question. So what we see is that obviously we've had this massive reduction in antibiotic use in BC, which has been a real success. And as I mentioned, we haven't seen an uptick in unintended consequences related to that reduction. So I think the biggest causes of that huge reduction are changes to the guidance related to otitis media or ear infection. So previously, infants were often treated with antibiotics for ear infection. And then as we gathered more evidence related to clinical effectiveness, basically we realized that they weren't needed and that ear infection often clears up on its own just as quickly as it does without antibiotics. And you can often manage these infections with, or these conditions with pain medication. So now the guidance states that antibiotics should not be used for ear infection with some caveats. I'm not a clinician, but for the majority of cases, antibiotics are not needed. We also know that antibiotics are not needed for most like sinus, cough, cold, flu-related illnesses because they're almost always viral and antibiotics are not going to do anything. And we also know that the pneumococcal vaccine was introduced during that time period. And I think that contributed a lot to the reduction in the need for antibiotics for babies. So I think reducing unnecessary antibiotic prescribing is a massive area, and understanding what antibiotics work against and what they don't work against. And that a lot of conditions, antibiotics will not do anything if they're viral. We also know that that where antibiotics are needed, and sometimes they are, where they are needed, if that, as I mentioned before in the presentation, if the baby has some exposure to breast milk, whether it's exclusively breastfed, whether it's pumped breast milk with formula, whether it's donor breast milk, whatever it is, that the human milk oligosaccharides, or the sugars in that milk, help to replenish the bacteria in their gut and reduce their risk of asthma and atopic disease. I hope that answers your question. So if the findings of this study is shared with the powers that be, i.e. the government, perhaps in the near future, asthma sufferers may have a class action suit. Well, that's not up to me, but we're doing our best to share the findings with policymakers for sure. I think what this study really shows is that it just adds evidence to the need for antibiotic stewardship in the community, and to providing new parents with supports for breastfeeding, and really adding to that evidence base, and being used as a kind of another tool in their arsenal, if you will. Big focus of our work has been to try and reach out to other jurisdictions around the world to get them to replicate this study, because in BC, obviously, we've seen a lot of investment in antibiotic stewardship in the community, which has led to great successes and has seemingly led to reductions in, at least partially attributable reductions in asthma. So what we want to see is jurisdictions where they haven't invested as much in antibiotic stewardship in the community, or don't provide as much support for breastfeeding parents, and see if we can make a real change there. So we're kind of trying to use BC and Manitoba as a bit of a test case for the rest of the world. Any other questions, or if anybody wants to speak as well, I'm happy with that. If not, I just want to thank everybody for your time in coming to listen to me talk about epidemiology and the ins and outs, and also for your generous support of the work that we do. The knowledge translation side, I think, can sometimes be a bit forgotten about, and in reality, it's incredibly important. It's one of the most important parts of the process, is getting this evidence into the hands of people who need it. So thank you very much for your support, and we look forward to keeping everyone updated. Okay, so Mark, do you think that's time to?
Yeah, I think if no one has any more questions, I think that pretty much wraps it. That was incredibly informative. Thank you so much for all the detail there.
Thank you.
Yeah, and also thank you for the land acknowledgement in the beginning. I slipped on that. Yeah, that was incredible. Hopefully we can do more of these. That was so informative, and I really liked the slides that you had prepared there. Very detailed.
Thank you very much.
Yeah, so if no one has any more questions, I'll go ahead and end the meeting, and then we can maybe chat about like getting the slides for participants. Is that a possibility, or is
yes.
that, yeah, okay.
I may have to, I'll just check with our data providers, but yeah, I'm sure we can figure something out.
Of course, yeah. Okay, great. Well, if that's all, then I'll go ahead and end this.
Okay. Thanks,
Okay.
everyone.
Yeah, thank you everyone for joining.